Want to record. So today's module is on pain management. Alphonse Daudet says, pain finds its way everywhere into my vision, my feelings, my sense of judgment. It's an infiltration. You have to die so many times before you die. I thought that was pretty interesting. I just wanted to share that with you guys. Let me go ahead and get started with okay. Today's session is dealing with pain management, and we'll discuss some intro. We'll talk about the assessments that are related to pain. There'll also be a section about pharmacological therapies as well as some principles of pain management. If someone would let me know that you can see this video, I certainly would appreciate it. You guys can see it?
We can see it.
Okay, great, great. Okay. So today's objectives, we're going to identify some barriers to adequate pain relief in serious illnesses, list some components of a thorough pain assessment, as well as take a quick look at some pharmacological and non-pharmacological therapies. And I want to put this disclaimer in there. I know that we have nurses as well as other disciplines on the line. I'll try my best not to go too deep into the pharmacology, but I do want you to know that there are some things that we'll look at as far as pain relief related to pharmacology. And then also discuss the role, not only of the nurse, but of the whole IDT team that's involved with the pain assessment. Because believe it or not, that every member of the team can kind of help as it relates to getting to know that patient and understanding their culture behind pain and their spirituality, things of that nature. According to the NCP guidelines, this is domain 2 that deals with the physical aspects of care. And of course, just want to say that the IDT team as a whole endeavors to relieve pain and suffering and to improve quality of life. And that is as it is defined by the patient and the family. Doing that by timely reduction, safe and timely reduction of physical symptoms and functional impairment for that patient. Also, the whole IDT team can kind of play a part in assessing those physical symptoms and the impact that it has on the patient's well-being, quality of life, and their functional status. Those care plans address physical symptoms, they maximize the functional status, they will enhance the quality of life that are developed in the context of that patient's goals of care, their disease and their prognosis, and also their limitations. So the first section we're going to talk about today is intro to pain management, of course, and we'll deal with kind of understanding what pain is, talk about the multidimensional approach, also some barriers as it relates to pain assessment and pain management. And we have a case study or two that we'll talk about as well. Pain is described as an unpleasant sensory and emotional experience that's associated with or resembling that associated with actual or potential tissue damage. Pain is also extremely subjective. It is going to be exactly what that patient says it is. You know, they could give it their own meaning behind it as to what it is. There's a thin line at times with patients between their report of pain as to whether or not, I know that as professionals, sometimes we've seen this where, you know, there's a thin line between genuine pain and pain med seeking. And that's sometimes a tough obstacle to try to hurdle. But, you know, as professionals, we're supposed to listen to the patient and to understand them. But we also know that through assessment and paying attention, if you're you know, provide medications as a, you know, if you're a clinical professional and you've never seen pain drug seeking, it's really a phenomenon all by itself. And that's all I'm going to say on that. But it can definitely be taxing. So, and also just knowing that pain can be actually described by different people in different ways. It varies from patient to patient. Pain also has a biophysiological, psychosocial, spiritual, and existential model that says, from a biological standpoint, there may be a question where we ask, what's caused the pain and what are the treatments? From a psychological, is there anxiety, Is there anger? Is there depression? Does it cause sleep disorders? From a social standpoint, um, does the patient have external support systems? What's the financial status? Are there substance use disorder issues? What are some of the values and the beliefs, and then the cultural beliefs and rituals related to pain? And from a spiritual standpoint, may ask the question, is there any existential distress? When we think about pain as it relates to cancer, of course, we know that serious illnesses does not revolve strictly around cancer, but this was given from Cohen and all, a statement from NCI that says 80% of patients that have advanced cancer have moderate to severe pain. And of course, some of the challenges for these patients to receive pain management would be the fear of, thinking about, well, if I'm in pain, that means I'm getting worse. I don't want to appear weak and, where I can't handle the pain and they're going to take away, some of my treatments, and not wanting to distract the provider with, um, asking or complaining of pain. Don't want to appear to be a drug seeker. And patients may believe anything, that everything is being done for their pain. Some non-malignant diseases and pain, of course, that would take an assessment of looking at some of the comorbidities that could cause the pain. An example, diabetes, some osteoporosis, maybe previous surgeries. These are some cardiac, renal, pulmonary, these can be some non-malignant pain as well. So when we think about research or the need for more research so that that pain can properly be treated. And of course, being able to do that would just make sure that we are able to assess and also be able to treat pain. Some effects of pain that does not get relief. Pain associated with depressions in patients with heart failure. Pain was associated with that depression. That also, think about it, depression affects the overall quality of life and the total outlook in life. So, we'll go from physical pain to emotional pain to, and that's a total overall decrease of the quality of life. Some inadequate pain relief can actually hasten death by increasing that psychological stress. And that, of course, that's the body's response, both physically and internally, to stressors that disrupt homeostasis. Decrease immunity, it can decrease mobility, increase the possibility of things like pneumonia or thromboembolism, and of course, increase the workload of those heart and lungs, the heart and the lungs. Barriers to pain relief. There are some specific barriers coming from 3 different areas here that I just want to touch on. From a standpoint of a professional, some barriers that healthcare professionals may experience would be, not having enough knowledge about pain assessment and management. Maybe poor assessment of the pain because of lack of time, not being able to feel like they're able to do a complete or a full assessment. Concern about regulation of controlled substances could be a barrier for professionals. Fear of the patient diversion or, having some substance use disorders going on. Concern about the adverse effects that it's going to have on their patient from analgesics. And of course, concern of the patient becoming tolerant to those. From a standpoint of an overall system, some barriers to pain relief could be, of course, inadequate staffing. That's number one. The priority may be low when it comes to giving pain treatment.
Whether you're a chaplain, whether you're
inadequate reimbursement. Also, problems with availability of treatment or access to it, because a lot of times opioids are not available in pharmacies in areas serving those vulnerable populations, such as, people of color, as well as in the rural areas. So we have to work to ensure that those necessary meds are available for patients, regardless of their environment. But of course, that still doesn't stop it at this point to being a barrier to making sure from a healthcare system standpoint. So some barriers that patients and family members may have to pain relief would be, like I said earlier, they don't want to report the pain because fearing the disease is worse, that the disease is worse if they're, start complaining of pain. Concern that that physician may become distracted from treatment, not being a good patient, not really wanting to take pain medications, um, being thought of as being an addict. Some patients and even family members feel like pain is just a natural part of illness and just can't be relieved. Those side effects, they worry about those unmanageable side effects. Tolerance, they think about not wanting to be tolerant. They feel like they need to be stoic or to be able to handle pain. Also, poor communication from older adults. They may deny pain, but when you've asked them specifically about certain sensations like aching or hurting or discomfort, they may respond a little bit better. So just those communication barriers in the older population. If we look at some strategies to overcome challenges in pain management, education of healthcare professionals, of course, would be include attending, lectures or education, making rounds with the pain specialists and maybe those from palliative care, or, continuing education as it relates to pain. Overcoming those system-based issues could be advocating for increasing the availability of pain and palliative care services. The management, use current guidelines, maybe the American Society of Clinical Oncology or World Health Organization, organizations like that, to be able to help with providing and providing an interprofessional approach. Also being able to monitor those outcomes and attend to those adverse effects. The education of the patients and the families, just making sure that they have some realistic goals set as it relates to their pain treatment. And of course, informing them that, pain can be addressed. And of course, providing that psychosocial support. And always with anything, and that's just continuing to learn and to develop more research around that. Here are some goals that are according to NCCN when it comes to thinking about pain management. Of course, providing adequate pain and symptom control. Want to decrease the distress that pain causes in both the patient and the family member, because seeing a family member in severe pain can be distressing on caregivers, family members as well. Provide them with an acceptable sense of control, because I want to remind you, the patient is driving this care plan. We are simply on board to provide services to them. So, one of the things we want to make sure is that they can have some sense of control of the situation. Relieving the burden of caregivers that deal with these patients that are in pain. And of course, being able to strengthen the relationships and give a better quality of life. And also enhancing the meaning of life and illness, and allow for personal growth even in end of life. So when we look at pain and suffering in serious illness, the existential distress, that's that fear of the dying process, and even some grief, it may cause us patients to alter their expressions when they think about pain. Well, when you think about what role does spirituality or religion, that could play a big part in a patient's perception of pain and or of receiving treatment for pain. We think about things like forgiveness. What is the meaning of the illness, and what is the role when we think about patient accepting that death is near? Also, the dimensions of the quality of life, just making sure that we can communicate with those patients that, providing hospice and palliative care is not waiting on them to die. It's allowing them to live the best quality of the life that they have left. And of course, from an interprofessional approach, when pain can't be prevented, we've got to make sure that we can at least relieve it. patients that are at risk for not getting enough treatment or under treatment, of course, are going to be children and older adults. Um, Also, the cognitively impaired or nonverbal patients that feel the need to be stoic or that say, I don't have any pain. The communication barrier, of course, from non-English speaking patients. Also, the cultural considerations that have to be kept in mind as it relates to, you know, different cultures and the way that they view pain and the treatment of pain, and also other cultures where certain members of the family, just there's all kinds of things to take into consideration when we think about treating pain. If I have a headache, I'll go to the medicine cabinet and take a Tylenol, but according to various cultures, that may not be an option. So those are just things that we need to just keep in mind. Also, making sure as far as a history of being addicted and things like that. Another set of patients that are at risk for undertreatment, of course, those that don't have insurance or they're underserved. So Lee Major is a 62-year-old male that has a history of congestive heart failure, emphysema, and type 2 diabetes. 5 days ago, he fractured his clavicle and proximal humerus due to a fall at home. He's just returned home from the hospital, having his humerus pinned. He declined participation in rehab due to exhaustion and difficulties with transportation. Unfortunately, he's still having moderate to severe pain. He's about at a 7 out of 10. So 2 years ago, he underwent a left below the knee amputation. He states he still has phantom pain, about an 8 out of 10 there. In addition, last year he had shingles, and today he still reports that post neuropathy pain, about a 5 out of 10. The only pain medication that he was sent home with today was oxycodone and Percocet, 1 tablet by mouth every 6 hours. He has no other pain medication at home. He was given 30 tablets. So in the past 6 months, Mr. Majors has made 3 911 calls to be taken to the emergency room because of severe dyspnea due to emphysema and CHF. Most recent ejection fraction is 35%. And because he lives alone, he has other health issues. Because he lives alone and has other health issues, a home care nurse is going to be following him once a week for the next 4 weeks. Now, I'll ask you guys if you would to unmute with me for just a minute and tell me, does that sound familiar?
Yes.
And let's talk about this gentleman's pain. The incision site, 7 out of 10, phantom pain, 8 out of 10, residual pain, 5 out of 10. Where would you start to manage these various sites and types of pain?
I see the list of meds prescribed pain.
I hear an echo. I'm sorry. I can hear you, but it's like echo, and I'm not really sure.
Is there a list of meds that are prescribed?
Yeah, the only medications that he was sent home with today was oxycodone and acetaminophen, Percocet, 5 and 325. So 1 tablet by mouth every 6 hours for pain. He has no other pain medication at home, and he has 30 tablets.
Yeah, so he's got poor symptom management. He's got no management of his neuropathy or neuropathic pain. So I would start there.
Yeah.
He needs gabapentin.
I'm sorry?
Say I muted again, so it didn't matter.
Say what was it?
Like I said, I think he needs gabapentin.
Oh,
Maybe
yeah.
some-
Yep, I would say so for that neuropathy. I guess you're right. Yep. Anybody else? So when we think about the changes that are how to go about addressing him, he's also got, let me ask you this then, because he has this varying multiple areas of pain, would he benefit from palliative care?
Well, sure, for symptom management.
That's exactly right. Because here's the thing, it said that he has the extremely strong pain medication, but he has phantom pain. He has some neuropathy going on. But I think that palliative care would allow him to have a care plan. He has a nurse coming once a week for 4 times a week, but getting in front of that and providing a care plan with goals to decrease the pain. But then not only that, make sure that his perception of pain and that he's able to express his levels of pain. And it didn't say that he wasn't able to, but I'm just thinking about when you have a care plan and in place, and you can, explain to the patient or let them explain to you kind of what they're feeling, so that we can keep with from a baseline and kind of see where he goes from there. Anybody else have anything else to add to that?
I think he would need a social worker. Also, he's an amputee. He's
Yes.
post-op. He has poor symptom management. And he has, I thought I heard you say something about ER visits with shortness of breath.
Yep.
So yeah, he's got a lot of needs. He needs a little bit of closer care.
Yeah, I would definitely say so. He needs some care in his life, because it sounds like he's just doing enough to get by. So he would definitely benefit from intervention from palliative care. Thanks, guys, for just adding in on that. I appreciate that. But when you think about culture, how it affects pain assessment and management, just looking at things like the preferred language. I don't know if anybody's ever had to try to treat a patient that doesn't speak the language. And of course, there are resources out there. I remember when several years ago in the hospital, they had the red phone, and I don't know exactly what may be all out there now. I know that there's apps on the phone that we can use to kind of make sure to be able to get from our non-English speaking patients, try to get a better picture of what's going on. But then also the idea of health literacy. I can't tell you how many times that I have had to speak the language that my patient understands. And then explaining what I mean when I say certain things, just putting on their level to where they can have an idea of what's going on. Because remember, the patient is driving this care plan, but he can't drive if he doesn't know where he's going. So, and then of course, looking at the fear of pain medication, the concept of what it means to be in pain and suffering. And then of course, pain versus hurt. And that's a big one, because I think, especially when you think about the older patients, their idea of what they're feeling may not be specifically, may not be able to specifically give you exactly what they're going through. Until you have to kind of do like a word soup to say, is it throbbing? Is it stabbing? Does it hurt to stand? Does it hurt to sit? Those types of things. So just keeping in mind that, is it pain or are they actually hurting? Those are the kinds of things that we have to look at to make sure that we're being effective in assessing and managing patients' pain. Of course, the ethical responsibilities, being able to provide excellent pain assessment and management. Treatment of being able to be assessed and treated for pain, that's a basic human right. But about 80% acute unrelieved post-operative pain, that is quite a bit when you think about patients that have undergone surgical procedures. That's what they kind of experience. And then, of course, 75% of those that have post-operative pain report moderate, severe, or even extreme pain. 25% in nursing homes receive no intervention for pain relief. And then, of course, unrelieved pain may lead to requests for medical aid in dying. Could you imagine someone saying, I hurt so bad, I'd just rather die. But they feel like that there is no help for the pain that they're in. And their mindset just turns away from getting some relief. And they look at relief as being taken completely out of the situation. So as a nurse, the ethical responsibilities, of course, is being able, assessing and managing pain. That's ethical legal principle for all nurses, with the ethical tenets of beneficence, which is the duty to benefit, the non-maleficence, that we're not going to do any harm. Autonomy, we're going to allow those patients as best as they can to have their own self-determination. And of course, justice, that's equal and fair access to everyone for pain management. We'll move on to section 2 that kind of starts dealing with the pain assessment. Of course, if we're going to obtain a comprehensive pain history, and of course, in doing that, that's being able to determine their benefits, their beliefs about pain that might interfere with them reporting pain, because self-reporting of pain, that's the gold standard. Because if they're not able to self-report, you have to look for things like the nonverbal behaviors or the nonverbal cues as it relates to pain. And of course, being able to take a look at their history, whether or not it's acute or chronic, conducting a current and thorough physical exam, and then also, of course, evaluating those lab and diagnostic testing just to make sure that we're checking all of their values as it relates to pain, because things like that are affected by pain, we just take a look at those values as well. And then also being able to communicate with the interprofessional team. Some goals when it comes to assessing pain. Excuse me. Determine the pain diagnosis, as well as the etiology of pain or where it's coming from. Nociceptive or neuropathic pain, acute, chronic or acute on chronic, and response to those pain interventions. Excuse me. Pain assessment, of course, we want to know where it's at, how bad is it, what's the quality, what are some of the factors with the pain, is there anything that makes it worse, anything that makes it better? What have you had in the past as far as what medicines have you taken for pain? What kind of treatments have you had for pain, whether it be massage or music therapy? And then just integrating, what have you done to integrate for your pain? And of course, the meaning of pain, some of the associated symptoms, the function, what level are they able to function related to pain, the risk assessment, which will be whether or not they have a past history of substance abuse. Is there a family history? Is there a history of abuse overall? And what are the goals of care? The P, of course, in a pain assessment is for the precipitating factors or the palliating factors and the previous treatment. The Q stands for quality. The R is for the region or the area where the pain and the radiation. Does it radiate outward or does it come, does it move all over? The severity is the S. And of course, the T is for the temporal. Physical examination, when you start thinking about pain, would be that the observation, the palpation, the listening for it, and also the percussion. Lab and diagnostic evaluations, of course, going to rule out some potentially treatable causes of the pain, and also the need for more lab or x-rays or evaluations directed by the goals of care. Again, you got to stay aware of the patient's goals of care. Are they going to be able to, I was thinking about the x-rays, are they going to be able to lay on the table for that? What about the cost? What about the cost to undue burden to the family? Outside of the boxes of thinking about the things before we start ordering these types of all these extra things for the patients. When we reassess, of course, we're going to look for changes in the pain. Has it gotten better? Is it worse? Is it just a dull ache now, whereas before it was a throbbing pain? And what is the response to the medicine that they're taking? Does it give relief? Does it cause side effects? And does it make the pain more visible? It has to be pain has to be made visible, meaning adding pain intensity scores to the same part of the chart where temperature, pulse, and other vital signs. In other words, we got to be able to say 5 out of 5, report to 5 out of 5 on the pain scale. When we begin to communicate those assessment findings, of course, clear communication, both verbally and in writing, of that assessment will ultimately improve the overall pain management. Describing the location, the intensity of the pain, whatever limits of functionality there are that result from the pain, of course, and the response from the regimen. These are the things that we need to describe in our communications. Also, to describe on the effect of, we have to describe the effect of his function, the patient's function as it related to being on the pain medication. Also, document the meds, the efficacy, and the adverse effects. Ask for suggestions, but be ready to make recommendations as well. And also, and this is, I guess, if I could say anything on this slide, that would be the most important. And that's, of course, being objective in all your recommendations and all of your conversations with the patient and family member. Going to move on to some pharmacological therapies. We'll talk a little bit about non-opioids and then opioids and adjuvants and routes of administration. Some non-opioids, of course, are going to be the acetaminophen, the Tylenol, the analgesic, and the antipyretic. High doses, of course, can actually cause some liver dysfunction or some issues with the liver. And of course, we have to be, because they're older adults, everything slows down within their body. Of course, have to pay close attention and use it cautiously, in the older adults. Of course, keep in mind that acetaminophen is present in a lot of different products. So we have to consider the amount in the compounds when we start thinking about drugs that, are going to be used for pain. It's important to ask them about all the medicines that they may be taking to make sure that we have a great understanding of how much acetaminophen they're actually taking. So non-opioids, or the NSAIDs, they are used as antipyretic, anti-inflammatory, and analgesic. Have to be so very careful to stay away from toxicity as well as adverse effects. I just wanted to say the NSAIDs, of course, in every population, but especially in the older population, they produce a significant toxicity in the gastric area through local effects and systemic effects. So they migrate through that gastric mucosas into the epithelial cells that line the stomach. So, actually burning literally with acid, like burning holes in the stomach. I was brought to the attention of that, just how powerful it was with my mother, where she literally, on just a very short time of taking NSAIDs over opioids, suffered severe bleeding ulcers in just a short time. And I think it was from over years and years of her lining. Of course, she was 87 years old and everything just kind of broke down, but her lining was so very thin that the NSAIDs literally burnt holes in her stomach, like in just a very short period of time, and she began to bleed. So some of the most commonly used opioids in palliative care are here listed: the buprenorphine, the codeine, fentanyl, hydrocodone, hydromorphone, methadone, morphine, oxycodone, oxymorphone, tapentadol, tramadol. And these are kind of used for a couple of things, for some nociceptive and also some neuropathic pain, because there's so many of them. There's sometimes where you'll find the docs want to rotate around. The fentanyl, of course, can be administered spinal, transdermal, transmucosal, and by nebulizer as well. Let me break down to this buprenorphine. It's an agonist used for pain control and medication-assisted therapy. Also, it's found in tablet strips, injections, a transdermal patch, has less risk for that respiratory depression, and is safer for those that have kidney malfunction or impairment. Methadone, on the positive side, it can be found in oral tablets, liquid, parenteral formulations. It costs less and works well for neuropathic pain. But some of the challenges, of course, is the same thing, that it comes in oral tablets, liquid, and then it's used that is inexpensive, and it can be used for neuropathic pain. You see here. Opioids, some of the adverse effects of that, of course, is the respiratory depression. They can cause constipation, sedation, urinary retention, nausea, vomiting, itching, and myoclonus. Some of the definitions, of course, a substance use disorder we'll talk about. We'll talk about tolerance. We'll also talk about physiological dependence. So let me go back here and touch on this. The substance use disorder is referring to the recurrent use, of course, of alcohol, substances that cause health problems, disability, and failure to meet responsibilities, whether it be at home or work or etc. It's primary, chronic, and a neurobiological disease. It has genetic, psychosocial, and environmental factors that influence the development and manifestations. It's characterized by behaviors that include one or more that would be impaired control over the drug use, compulsive use, or continued use despite of the harm, and then craving. And of course, tolerance is when the body is able to build up it no longer works, or it no longer is effective. And so when they build up that tolerance, then that just increased the need for more and more and more. And of course, when we think about a physiological dependence, that's where they feel like they cannot live without it. Just there's no way that I can get better or feel better unless, it affects not only the body, but the mind as well. Drug overdose, of course, is the leading cause of death in those under 50 years of age in the US. And the challenge is, how in the world can we reduce the pain and suffering and contain that toll of the harm that's caused by the misuse? Opioid crisis is not brand new, guys. It has been around, and I don't think it's going anywhere anytime soon. But, nurses have to be able to balance these concerns through, the comprehensive assessment of pain, the function, and the risk of misuse. Got to be able to balance all three of those, as far as also making sure that, looking at the careful prescribing of those substances, considering the risk. Of course, that's if it's a part of the scope of practice. But then even the clinicians, the docs, we need to hopefully they're cognizant of this, because the opioid crisis, like I said, is not brand new. It's not something that's going away. How do we prevent unintended consequences of efforts to control misuse and to protect access to opioids for those that have life-threatening illnesses? This is one of the many challenges that we face as we start thinking about providing opioid therapy to patients. Adjuvant analgesics or antidepressants for patients that have moderate to severe pain. Of course, opioids are generally that first line therapy, but sometimes antidepressants can be used for opioid refractory neuropathic pain. But for some of that neuropathic pain, antidepressants, they become the first line of treatment. So the mechanism of a tricyclic antidepressant is supposed to be related to the inhibition of norepinephrine and serotonin. These agents, they are useful in the treatment of that neuropathic pain. As a result, they have sedating properties. So sometimes nortriptyline is used more often in those with sleep disorders and pain. And of course, then also there are the serotonin, non-epinephrine, I cannot say that word, reuptake inhibitors, or the SNRIs. Then also there are some anti-convulsants that can be used for neuropathic pain. Gabapentin, I know we mentioned that earlier when we were talking about Mr. Lee, and then pregabalin. And the recommended dose, of course, for the gabapentin, 100 to 300 milligrams 3 times a day, that can be titrated gradually. for the pregabalin, 50 milligrams 3 times a day for 1 week, and then up to 100 milligrams twice a day or 3 times a day. Local anesthetics, of course, there's lidocaine gel, lidocaine cream, lidocaine patch, IV, and then even spinal. Some other topical agents, of course, is menthol and camphor, diclofenac gel or cream, and the capsaicin cream or patch. I'm rolling right through this, guys, because I don't want this to be a whole pharmacy education. So when we look at some corticosteroids, they're useful when they treat neuropathic pain, bone pain, and visceral pain. They're effective in reducing inflammation that's related to like a tumor, which opens the airway, or gastrointestinal obstructions that are caused by those malignancies. Of course, it activates and increases the appetite. Look for proximal muscle wasting and administer every morning is the indication for that. Cannabis used to treat pain and other symptoms is becoming more and more popular and more legal across the nation to permit its medical and or recreational use. Of course, there are now some FDA approved forms, as well as, you know, it has multiple routes of delivery. You can eat it, you can inhale it, and of course you can smoke it. So the clinical practice, of course, include just knowing those federal and state laws governing that medical cannabis. Also, be clear with the patients about their goal for therapeutic cannabis, if that's what they have been prescribed. Also, counsel the patients about the routes of administration and the benefits and the risks of that based on evidence and individual symptoms, conditions, and those comorbidities. Talk a little bit right now about some routes of administration. Of course, here they're listed, and I may be able to go a little bit deeper into each one of those if I can. Oral, transmucosal, buccal, sublingual, nasal, rectal, transdermal, and topical. Parenteral, which is intravenous, subcutaneous, intramuscular, spinal, epidural, and intrathecal. Tell you what, let me go back, make sure. Okay, thought I skipped something. So I have another case study. Miss T is 86 years old, and she has a history of type 2 diabetes, CHF, renal failure, and she's been diagnosed with stage 3 colon cancer 10 months ago. She underwent surgery and only had 3 rounds of chemo because she refused. I'm not taking any more treatment for cancer. She fell and broke her hip about 2 days ago. Yesterday, she underwent surgery and had that hip pinned. She has multiple sites of pain, the incisional hip, back and neck pain from osteoporosis. She has neuropathic pain from diabetes. Her incisional pain is an 8, and her other cited pains are self-stated as a 6. Physical therapy has come into the room to start her therapy. And from your assessment, you know she needs more pain medication to do what physical therapy is about to have her to do. She's currently getting a continuous infusion of morphine, 1 milligram IV per hour with no breakthrough dosage. She's been taking 2 tablets of hydrocodone, 5-325 in the morning and at night, PRN, since she had colon surgery 10 months ago. So if you can unmute for me and just think about being a nurse in this situation, discussing these findings with an orthopedic surgeon, and the surgeon says, I'm afraid I'll overdose her due to her age. Be sure to talk about let's talk about the location and the various pains, the intensity, the limitations, and the response to the current treatment. Anybody want to weigh in on this? And whether or not she's considered opioid naive.
I'll weigh in.
Okay.
I'll just say that if she had baseline opioids in her system chronically, and so we're probably not matching even that. with the 1 milligram per hour of morphine continuous.
Right.
So probably undertreated. I'm not looking at equianalgesia, and I can no longer do that in my head, but I would assume that we're probably undertreating until we're not even accounting for multiple types of pain and for this new acute pain from the hip. So I would ask him to kindly consult palliative care to manage her symptoms better.
Yes, kindly consult. Let me ask you this. Looking at where she is with the pain levels that she have, do you guys see potential for anything, any other concerns, emotional, psychosocial, anything like depressed? Can you guys kind of speak to me about that? Because I know we're talking about physical pain, but remember that it's just one step away from another pitfall or another pitfall. So can somebody speak to that? Did my question make sense?
I don't want to be the only one on here talking, but I I feel like she's not going to eat and drink well if her symptoms are not managed well. She's not going to get up with physical therapy if her symptoms are not managed well. Um, Pain affects every part of you, and so your ability to be positive and optimistic that you can recover from this particular setback is going to be limited if we don't, first manage her pain, and then address other issues that may be at hand for her. I mean, she does
Right.
have a stage 3 colon cancer.
Right.
So I'm not sure the treatment, what the status on that is for her, but she's had a change in her ability to function in her normal way. She's elderly. So there's a lot of possibilities.
And I'm thinking about the fact of, let's just say, physical therapy is coming in, they're going to want to get her up, and her just knowing that she's in pain, not only is it going to take her to the point where I'm not going to want to get up, but then she'll start, she could possibly start thinking, you guys are trying to kill me. I don't even want to be, so I could just see it pivoting into so much more. Just like you said earlier, just from being undertreated, because I definitely would say she's being undertreated at this point. But when you don't feel good, you don't feel good. And I can speak for that myself, that when I physically don't feel well, if I'm not careful, it bounces off and becomes so much more. So such is the same with patients, and then they get to the point where they don't want to have anything to do with the physical therapist, with the nurse, with anybody. All of you get out. So, I can definitely see the potential for that spiraling into something so much more. Thank you for your comments. Anybody else? No? Okay. So what would be your response to the doctor when he says, I'm afraid I'm overdosing her? I'm just curious, as a nurse that's standing beside a doc, what would you say to that?
Yeah, I don't know the politically correct way to respond
I
to
don't
that.
either.
Not
I don't
overdosing.
either.
She's probably awake and alert and uncomfortable. Um, we're gonna see. Yeah, I would say, why don't we call palliative care and see if they can manage her?
Yeah,
Sometimes if you take the ego into account, that's just a great way to get palliative pulled in,
right,
uh, and not offend him at the same time as the surgeon that fixed her body, right? He fixed her hip.
right, right.
Thank you for that. And let's get somebody that's more comfortable
That's right.
in providing expert level pain management.
Excellent response. That was very politically correct. Section 4 is going to talk about some principles of managing that pain. Of course, this is the final section, but we'll take a look at a review of the following, thinking about regarding principles of pain: the opioid dose titration, some long-acting meds, the opioid rotation, substance use disorder, interventional therapies, some non-pharmacological therapies, and also the role as a nurse when we look at these. So looking at opioid dose titration, um, you kind of start that dosing with immediate release available, and then once they've gotten that pain relief for a period of time, just looking at calculating that 24-hour dose of opioid and convert it, go over to extended release. So kind of going from, instant to the extended release, and still using that immediate release for breakthrough pain, and being able to understand exactly what the types of breakthrough pain are. So when we talk about, I missed a point in thinking about the breakthrough pain, because it could be like if they move, it causes it, or if we don't know what's causing it, it's just at the end, or increased pain before the next dose. So kind of burning out before the next time for the next dose, they're already losing the effectiveness of the pain. So looking at rotating the opioids out, we use when one opioid is ineffective, even if we're titrating it correctly, if it's not relieved by it, even though, like I said, we're doing what we've been ordered to do, when the patient experiences side effects, it's warranted to rotate those opioids out. And of course, whenever the side effects are not manageable, we kind of rotate out to be able to improve pain relief and or that drug intolerability. Keep in mind that if one opioid is not effective after an upward, after you bump it up a little bit, or if it produces those side effects, then you may need to go to another one. Of course, if morphine gives you little relief, you need maybe switch to hydromorphone or oxycodone. Some principles of equal analgesia. Need to be able to determine equal doses when changing drugs or those routes of administration. It's kind of pharmacological. I'm going to try to stay away from that, but using oral morphine equivalents and reducing that by 25% if you're changing the drugs. And of course, this link here should be able to take you to those fast facts to kind of give an assistance when you're thinking about the figuring of those drugs. Treatment of pain in persons that have that substance abuse disorder. Of course, you're going to look at this from an interdisciplinary approach, and set some real goals, set some real limits. Use those non-opioids as best you can. Consider the patient's tolerance level, and also get some some specialist advice on this. Because, dealing with assessing and even treating patients that have that substance use history, it can be really challenging. So, just making sure that we stay consistent and set those limits, and, utilize the whole team and the whole gamut. Because the goal of pain management in the face of substance abuse treatment harm is to reduce that control use with the hope of minimizing the interference with the effective symptom control. Treatment of pain in persons that have order. This is a continued slide. Want to avoid parenteral injections if possible. Try to prevent withdrawal. Treat depression and other psychiatric disorders. Use alternate opioid if they're on methadone for maintenance. And then, of course, always use those universal precautions. Some cancer therapies to relieve pain. Of course, radiation, there's surgery, radiofrequency ablation, chemo, immunotherapy, hormonal therapy, and bisphosphonates. Some interventional therapies, neurolytic blocks, neuroablative procedures, and vertebroplasty or kyphoplasty. Some non-pharmacological strategies to think about pain, of course, rehab, exercise, heat, cold, the TENS units, some cognitive behavioral therapy. Those are from the physical aspect. From the psychosocial standpoint, we may look at relaxation and meditation, music therapy, hypnosis, some biofeedback, systemic desensitization, and complementive and integrative would be acupuncture. I'm not familiar with that. Qigong, therapeutic massage, Reiki, and virtual reality. So looking at the whole idea of Pain relief is contingent on the adequate assessment and use of both drugs and non-drug therapies. Pain extends beyond physical causes to other causes of suffering and existential distress. And of course, being able to provide excellent interdisciplinary care. I'll pause right there and ask a question as to whether or not what you guys would think when you think about using interdisciplinary care, that approach to comprehensive pain management. What would that actually look like? You know, where would you plug in a social worker in a scenario with this when you're thinking about pain management?
I know what we do on in our program is when we think there are other circumstances at hand with regard to the patient's pain experience, we will ask our chaplain and or social worker to go and assess them because there are almost always other things contributing to the total pain experience for the person.
You're exactly right. And even just thinking about suffering, you know, when we think about end of life and, you know, we think about pain, you know, pain can be so much more than just that physical pain. As patients approach end of life, you know, there are things where there may be some unresolved familial issues, some estrangement, some trust issues, you know, all kinds of psychosocial things that could actually only make the pain that they're feeling or the inability to get comfortable or even have a good death, if that makes sense. It makes it impossible when they're dealing with all these other things. So yes, definitely tag in the chaplain, you know, tag in the social worker. I've also even found that in times when, you know, patients are very close to the aides, the ones that are providing them with, you know, baths and feeding and things like that. You know, I have seen where they have been able to open up and have conversations with the aide because they form a sense of trust. It's a very intimate situation having someone take care of you or bathe you or feed you a couple of times a week. So just being able to get that feedback because I can't tell you how many times because a patient has opened up to the aide that the aide has been able to provide this information, thereby adding points to the care plan that was beneficial for the patient. You know, being able to say just because, you know, just in casual conversation, you know, she said that, you know, she feels this way or this would really help her, where she may not have had that conversation with the nurse or the other clinicians, but just being able to utilize the full interdisciplinary. Uh, and then also there's some people that are in spiritual crises, you know, things that may have happened from many, many years back that they've never been able to get peace about or come to a place where I can die now because I've got this off my chest or, you know, the hurt that I experienced as a child, you know, I never got a chance to get it right with whomever. You know, so when you think about pain, I know the first thing we think about is the physical pain, but when you also keep in mind that from a standpoint of palliative care and end of life care, pain could mean so many different things. So yes, definitely. And I also would like to add just a point here, being a social worker and a nurse myself, that you know maybe the nurse in the nurse's assessment may pick up on some cues or some things that she'll be able to communicate with the social worker so that when social worker goes to do their assessment, they have a better understanding. You know, maybe just giving you a tidbit of information, but thereby allowing that social worker to get a little bit more in depth as to the history of this soul crisis that the patient may be having, or that they're in so much pain, but to come to realize that it's not all just physical pain. It's pain from being, you know, estranged from their kids for 40 years or so many different examples, but just keeping in mind that that communication across the team is vitally important. Any questions? Well, I'll tell you this actual being an hour and a half is kind of designed for a little bit more conversation. You guys are a quiet group, and that's okay. Um, it is okay. And thank you for Christine and whoever else made comments. That is perfectly okay as well. but I do want you to know that the PowerPoint will go to everyone that's registered and that was on today. I'm going to do another quick run of the roll just to make sure I have everybody. And of course, like I said, I'll answer any questions that anyone may have. Okay, so I have Christine, Jacqueline, Monica, Jen. Who is iPhone 345?
I don't know. It may be mine.
It's,
I'm
no, it's mine. It's Dawn. I had to switch from my
Oh,
computer to my
okay.
phone.
Gotcha. Okay. Yeah, Sheila, I see yours says Sheila's iPhone.
okay.
I have
Right.
Randy and Tamika and Zulima. Don't let me mess your name up. Is that right? Zulima? I hope. Kristen and Tracy. Is there anyone else on the call that I did not call your name? Okay. In addition to the PowerPoint session, LMHPCO's YouTube will actually have this recording for this session as well. And anyone that has registered can also refer back to the video. Of course, it's not much of a video, just showing the PowerPoint and the discussion around it. But feel free. Of course, the certificates will be awarded at the end of these sessions. Again, I'll repeat, if you need to make up a session or if you know you're not going to be in a session, if you give me a heads up, I'll be happy to make sure that you get the PowerPoint as well as the YouTube link.
Okay, that's what I'm going to need, Miss Marquita.
Okay.
The first, I missed last Thursday. So
Okay.
how would I go back and review the video? Yeah.
So I think I saw that, and then Dawn as well missed last week. Is that right, Dawn? Is there anybody else that missed last week?
Yes, ma'am. That's right.
Okay. Okay. I will make sure to send you both that last week's session as well as make sure that you have the PowerPoint.
Okay, great. Okay.
Okay. Is there anyone else? Well, I gave you a gift of 25 extra minutes. You guys will still get 1.5 hours today. Thank you so
Thank you.
much, and I'll see y'all next Thursday.
Enjoyed you.
Oh,
Thank you.
thank you. Have a great day.
You too.
Thank you.
You're welcome.
Appreciate it.
Thanks.
You're welcome.